All right, well, we're going to get started today on our next episode of Stroke Wellness. And this is a program to increase the awareness of resources and information that can help optimize outcome during stroke recovery. So it's very important. We want our listeners to really understand that there are lots of resources out there. There's a lot of information that can be very helpful during that stroke recovery journey. And everyone's on a different journey, and everyone's situations are different. The challenges that each one has can seem similar in many ways, but also in just as many ways can be different. So we're going to talk today. We are very privileged to have with us today Dr. F Scott Feil, and he's the creator of PTeducator.com. He's an educational and business consultant, and he can tell you a lot more about the experiences he's had in education and as a physical therapist. So welcome.
Yeah, thanks for having me so much, Karen. I appreciate you having me on. I want to preface the episode by saying, I'm not an expert in diabetes or stroke. I'm just a physical therapist that's kind of been around the block a couple times. So
Yeah.
I've got a lot of experience in general, but also my wife is a type 1 diabetic. So, I think I've learned a lot over the years just with my own research because of having to. I mean,
Yes.
If your loved one is affected by a disease or a diagnosis, you want to learn as much about it as you possibly can. So, I'm just happy to be on here and talking about all things diabetes and stroke.
Yeah, that's good. It's really good. Regardless of what kind of physical therapy someone is doing, it's a really big possibility that you're going to work with somebody who has diabetes. Unfortunately, it is a very high prevalence in the U.S. and not, obviously type 1, but type 2 probably even more so.
Mm-hmm.
Could you talk a little bit about some of the contributing factors to type 2?
Yeah, sure. So let's make a very stern distinction right off the bat. There are two types of diabetes, right? I do a lot of home health work with patients, and when I ask their health history, a lot of them say, "Oh, I have high blood pressure and I'm a diabetic." And immediately I ask, "Okay, well, is it type 1 diabetes or type 2?" And a lot of them don't even know.
Yeah, interesting.
Which is really, really unfortunate because A, they're drastically different, and B, I feel like that's an area where our healthcare system could really be doing a benefit if they educated the patients a little bit more as to, what type of diabetes they have and how to maybe manage it a little better. So type 1 diabetes basically is the juvenile diabetes, they call it. And, your pancreas just doesn't work, right? It's not producing insulin no matter what you do. So if you eat food and it turns into sugar in your blood system and it gets too high, your pancreas can't produce any insulin to bring that level down of blood sugar. Same thing the other direction. If it gets too low, the pancreas doesn't shut off and stop producing insulin so that it can come back up again with, food, beverage, and sugar. So type 1 diabetes is the insulin dependent type. I would say it's a little more drastic as far as management. Patients have to be checking their blood sugars pretty frequently, a couple times a day, and then giving themselves insulin based on what they find with the blood sugars.
Yeah.
Good news is technology is getting better. We're trying to create a fake pancreas or an automated pancreas, and we're getting there. We're getting close. But my wife currently has a continuous glucose monitor, which checks her blood sugar every 5 minutes and tracks it on a graph and stuff, so she can check it right on her phone and see if she needs to give herself insulin or cut it back a little bit.
Right. Right.
So the finger sticks are slowly but surely going away. Blood sugars are being monitored a little more regularly, which is good. And there's even a closed loop system now where the continuous glucose monitor signals to the injection site of the insulin how much insulin is actually needed. So that's a neat little innovation that's come out over the last couple of years as well. It's still not perfect, but we're getting there. Like I said, we're trying to form the perfect pancreas, but not quite there yet.
That's right.
Type 2 diabetes, like we said, it's a little bit different. It's usually brought on by obesity, poor diet, lack of exercise, and it is prevalent these days in America. there's definitely a trend toward all of those comorbidities,
Right.
and we're trying to do everything we can again to educate the public on their general health
That's
and
right.
and what they can do to kind of manage that before. A lot of people are pre-diabetic, maybe don't even know it, or they do know it, and we can change that. We can change the direction. And type 2 diabetes is even reversible.
Yeah.
So just some things to note about the two different types of diabetes before we kind of dive in and really get into the nitty
Yeah.
gritty.
And for those with type 2 particularly, as well as type 1 though, there are real reasons to work on trying to decrease the problems of having type 2 diabetes if you can, because of the complications that happen with diabetes. So there are certainly things that we instruct our patients on if they have diabetes, to be sure and check. Their feet, their wound healing can be a problem, and sensation and in the limbs and vision and different things. So it is really a crucial thing, and it's
Yeah,
good if we can address that as PTs, I think.
exactly. And while we're talking about strokes here, there's a 1.5 greater chance of having a stroke if you have diabetes.
That's right.
So that's just an underlying side note there.
Absolutely. Yeah. Another
So
thing that I was doing a little bit of research and I didn't realize is that if you go into the hospital and you are having a stroke and you are diabetic, that can affect the actual outcome of the stroke more so.
yeah, absolutely. Because think about it, right? If if you've got diabetes over a long period of time, it changes some of the structure and some of the blood vessels, right?
Hmm.
And so if some of those blood vessels, are out in the head or the brain area, right? The head and neck area,
Yeah.
that could really cause issues with circulation, So with those pathological changes, it can lead to a worse stroke, right? And if the cerebellar vessels are affected, you're talking about possible bad news.
Yeah, yeah. They were
So,
even
so
talking
yeah,
about the brain cells that surround the area of like an infarct are not going to respond the same as well. I mean, it's
exactly.
not even just the vessels. It's like it
E-
affects your brain.
exactly. It just, you know, uh, it's hard to pinpoint those things. It's really a multifactorial thing, but big picture, you know, stroke's not going to help you any, or diabetes isn't going to help if there's a stroke going on.
Yeah,
So
yeah. I also read that um, people who are not diabetic might be but they might even just not even be anywhere near it. But just the stress of the stroke can cause hyperglycemia during the stroke, and
yeah,
that can also affect
yep. Just another
outcome.
thing to layer on there. Yep.
Yeah, it's amazing, really, just that effects of all these things. I think too, it might be good to go over some of the signs that someone's having either hyperglycemic problems or hypoglycemic problems, because you're on the street, or you're a teacher in a classroom, or you're a PT in a gym, or you're the person next to somebody on a train. What might indicate that someone is having an issue
Yeah,
related?
my wife generally, when she goes low, right, when her blood sugar's low and bottoming out, she feels very weak, lightheaded, dizzy, and just kind of like jello, like her legs are jello and wobbly. Um, when her blood sugar's too high, it's more of like a headache, sweating, tingling in the tongue or the mouth. Um, it's a little bit different for highs versus lows. But it is something to definitely be aware of. And one of the things that I've started learning just as soon as we got married was, all right, if she's running high and goes into like a, diabetic coma of some sort, here's how to inject her with her insulin, or if she's dropping low and bottoming out, throw some frosting under the tongue or some OJ, just something to get that blood sugar up immediately.
Yeah,
We've kind of got our diabetic crash kit next to the bed just in case,
yeah.
but
And
you got
sometimes
to
when
know
people
the
are having,
difference, right?
yeah, yeah, and
You've got to
sometimes
know,
people are
are they
having,
running too high or too low and what to do
yeah,
in response.
exactly. And if someone is needing sugar, they may not be very cooperative. True.
Yep.
So
Yeah. It's, I don't want to say it's like an out of body experience, but like they're just not themselves when they're having a diabetic high or diabetic low. You know, they can be cranky. They can be, like you said, just not cooperative. You know, and then heaven forbid you throw in a stroke or, you know, Alzheimer's or dementia or something on top of all that. Now we got a really interesting situation. So.
Exactly. Yeah, exactly. So someone has had a stroke and they end up in the PT department for the rehab. They're not probably moving very well. And one of the better ways to help regulate blood sugar is exercise. So that could be tricky.
Yeah, big time. I mean, there's basically two major things to focus on with diabetes and stroke. And that one is the diet and two is exercise. You know, over the last couple of years, we've kind of adopted a Whole30 style diet, which is, you know, we're not strictly all Whole30 religious about it, but 80-90% of our meals are no sugar, no processed foods, you know, no carbs, basically just vegetables, fruit, and proteins. You know, and overall that keeps her blood sugar like relatively moderated, right? And mine as well. Like it's been a great change for me.
Great.
And then you throw on top of that exercise and you've got, you know, at the very least, a healthy outcome. You know, if you know, if you really focus in on it, you can even, like we talked about, reverse type 2 diabetes. So it's just about being able to put in the time and put in the effort to eat right and exercise. Now, like you said, with stroke, that throws in a little bit of a complication because they're not able to move as well.
Mm-hmm.
So we got to come up with some inventive ways and some different ways to maybe get the heart rate up a little bit. You know, and the good news is there's some really good machines out there that can help, right? Like a new step machine that you can kind of adapt so that both feet and legs can do the work and maybe one arm can do the work and you get rid of the other arm if there's a, you know, an arm deficit. If there's a leg deficit, you can even strap the foot in to help with that. I've done that before.
Yeah.
You know, but something that they can do where they're, you know, not taxed overall, that the affected side is, you know, able to maybe go through the motions at the very least. Arm bikes are very good, I've found. You know, even stationary bikes, if they can, you know, both legs are doing pretty well, stationary bikes are okay. And a lot of them have the strap on the step on the pedal as well. So you can slide the affected side into the strap too, and they don't, you know, slide out of it. The good side can do all the work. But, you know, you got to be thinking about ways to try to get the heart rate up. And then you can kind of work on the stroke symptoms almost as an afterthought, I think. Like that can be a whole separate treatment. You know, one, we do some cardio and exercise. Two, we then address the stroke symptoms. So that's kind of how I look at it.
No, that's good. That's very, very, very good. I think too that you know, going through a stroke, it can be kind of disappointing. Obviously, people go through grief and discouragement. So becoming sedentary, you know, especially when rehab is kind of, you know, petered out a bit, that can be a problem, can't it? You know.
Oh, big time, big time. It's just like, you know, losing a limb, you know, or a death in the family. There's a grieving process with several steps that people have to go through. And depending, you know, some people come back from a stroke and are completely fine. Other people are affected for the rest of their lives and won't ever get use of a limb back, you know. So it is a grieving process, and you have to be aware of that. And you have to come along that journey with them. You can't try to force it or push it. You know, you have to really be well versed in those several steps and look out for them. They're not always in order. You know, there's a general trend to the way they go through them, but sometimes they're jumbled up, and there's just, you have to be aware of them and recognize what step they're going through and just be with them for the journey, you know. And that to me has been the biggest way to help, is just be there, you know. Don't try to force a square peg into a round hole, right? Just be there for the patient, listen to them and their needs, let them, you know, do what they have to do, and realize some of it's going to be, you know, projecting right onto you. Even they're going to be angry or mad. That's part of the grieving process. They might, you know, blame you, right? That's another part of the grieving process. It's not your fault, you know that. I mean, you just have to be aware that, oh, okay, they're going through this phase right now, I understand, and just be compassionate, you know, and be there for them. Really listen to them, let them vent whatever they have to vent, and then see if you can redirect into another activity or something that may help them in that session.
Absolutely. Yeah. And after time has passed, it doesn't mean that they're not ever going to revisit a stage of grief. Do you think?
Yeah, absolutely. I mean, it's just like losing a loved one, right? It just doesn't get better necessarily. You just cope with it a little better and deal with it a little better, but you can still slide right back into those grieving points at any point in time. They're just fewer and further in between, I think.
Yeah. And it's a marathon. If you have the diabetes
Absolutely.
and the stroke, the journey is long.
Yeah, big time. So again, just even more important to try to make sure either we don't go into a diabetic state, or that we can reverse it if it's already there.
hmm
Um, it's just super important because it's something that we can control, and there's no medications needed. It's just very simple diet and exercise. Um, Unless, again, we're talking type 1, that's a different story. But, as far as type 2 goes, and that's the prevalence in the United States, it can be very easily managed and even prevented. And that's where we need to start looking, I think, as therapists and healthcare providers.
Yeah. And I think what people probably need to realize is that diabetes can cause a cascade of other very serious things. I think of the cardiac problems that can
Yeah.
incur. When I go through people's past medical history, it's almost like it's going to come together. You're going to see diabetes, you're going to see cardiac problems.
Absolutely. Well, heart attacks, right? The silent killer. Again, it just goes back to the blood vessels being affected over a long period of time. With diabetes, that maybe the heart's not as strong as it was, maybe the vessels surrounding the heart aren't as good. You're going to get, like we talked about, circulatory issues down the legs and feet, which cause neuropathies and numbnesses and swelling, and which again then you come back to the heart. Now is congestive heart failure an issue? I mean, it steamrolls and it kind of snowballs out of control. One thing leads to another, and it just keeps going. So it sounds very 30,000 foot view, big picture, general health, but it really is. I mean, if we can even just control that one thing, 3 or 4 things down the line may be prevented.
Yeah. Yeah. And to speak to the person who's down the line, they've had the diabetes, perhaps it hasn't been well monitored, or they've been a brittle diabetic, and they are facing now all these cardiac problems. We want to also encourage anyone at any level where you find yourself, where there are irreversible changes and problems, that you still have choices in other areas, mentally, emotionally.
Yeah, I mean, at some point you have a new baseline, and it is what it is. And once you've gone through the grieving process, you've recognized, all right, this is the new me, this is the new baseline. I can't reverse this, I can't change it. Now I have to deal with it, right? At that point, you're looking at very minimalistic things, like literally one small change at a time, and whether that be even diet, right? Okay, well, I'm drinking 2 Cokes a day, or 4 Dr. Peppers a day. All right, well, maybe that's it. Maybe we just slowly wean you off the sodas and get off of them, and we just do water from here on out. Occasional black coffee or something. It doesn't happen overnight. It could be a month or 2 months or 3 months, but little by little we wean you down off them, and that's the new health tip, is water. You're off of sodas and you're on the water. That's just one small change that you made that may help you live a couple extra years. It may add a few years to your life. If you're struggling with just exercise in general because of all the comorbidities, right? Maybe we just work on one simple exercise, seated marching, just enough to strengthen the legs every single day so that you can get up out of the chair, right? Sit to stand becomes super important with independence, because it helps with going to the bathroom, going to the kitchen table, going to bed at night. If you can do that one thing and we can work on just that one transfer, that may be enough to really keep you going and keep you motivated and keep you moving and let you do the things that you want to do without too much help.
Yeah, absolutely. Yeah. Maybe too, if you're getting frustrated with other things in your life, maybe your living environment is not conducive for your disability or limitation, then getting, someone in to give recommendations for, modifications, or, take care of those stressy things that are outside.
Yeah, big time. I mean, stairs with no handrails. I've seen it all the time. Like how, if you've got one whole side affected, it's going to be tough to climb those stairs, especially without a stair rail, without a handrail, right? So maybe we look into getting you a ramp. Even if you don't need a wheelchair, that's fine. But the ramp will be easier to get up and into the house. Let's look at the toilet. Is it too low? Do you need a raised toilet seat? Do you need handles? Do you need a bedside commode to go over that to get you up higher? So it's easier to work on your sit to stands, right? The tub. Are showers dangerous now? Yeah, probably. So maybe we get you a tub bench, right? There's a bunch of different modifications. There's a bunch of changes that can be made that can just make your life easier at that new baseline. No matter how good or bad it is what it is. And now here's how to make things easier on you. Here's how to make things safer more than anything, right? Because the biggest issue is falls in the home. We don't want falls. Falls lead to broken hips. Broken hips lead to hospitalizations. Hospitalizations lead to really bad things. So that's where we're trying to avoid that stuff, right? That's the main goal for me always as a home health therapist is safety first. What can we do to make this environment livable for you, comfortable and easy, and safe?
And the aging patient. So they're going to see different problems as they go into the next decade of their lives.
Yeah, I think so. Again, right? We talked a little bit about dementia and Alzheimer's. I mean, shoot, if you're a diabetic, you can just have a high or a low that can shoot you into a brain fog anyway. You don't need diabetes or Alzheimer's or dementia. It can just be the diabetes kicking in and giving you brain fog. So, I think we definitely need to look out for that cognition. Is it just literally a blood sugar issue right now, or is it something more deep than that, something a little longer term and longer lasting? As we get older, our balance gets worse anyway. The ability, our proprioception, the ability to feel what's going on underneath our feet, that gets worse. So with the diabetic, if you've got neuropathies or numbness and tingling in the feet, it's going to double, right? You're going to get even worse feeling down there. So you're not going to know exactly what you're stepping on.
Yeah.
Which A, could be bad for balance, but B, could be bad for health. Like you talked about ulcers and wounds.
Yeah.
Diabetics heal slower too. So if you get a foot ulcer or a wound on the bottom of your foot because you stepped on a pebble and you didn't feel it for a week and walked around on it, now all of a sudden you got a hole in the bottom of your heel and it's getting worse. It's going to take a longer time for a diabetic to heal than it would for just an old person, right? So now if you're old and you're diabetic, you got two strikes against you, and it's just going to take a whole lot longer to heal that up. And if that doesn't heal, again, we look at amputations, right? Things are happening, gangrene, bad things going on in the foot. They may just say, hey, we need to take this foot off. And as soon as the amputations start, now you're losing mobility. Now you're getting into a wheelchair. Now things are getting much, much worse and harder to manage.
Yeah, and exercise is again going to be compromised, and diabetes is going to be affected. It's just a snowball.
Absolutely.
So take care of your health. It's such a big
right. That's the moral of the story. I mean, diet and exercise. I hate to say it because every time I go to my doctor, he tells me you need to eat less and exercise more. And I'm like, I know, doc. And he's like, to be honest with you, it's not even eating less. It's just eating right.
Yeah.
You got to eat right, eat healthy, eat real food, and move. That's the easiest way to help stay off medications, to help get you in the best exercise. You don't have to be Mr. Olympia. You don't have to be out there crushing CrossFit workouts and running marathons, but you do need to move more than just, I get up and I walk around the house every day. Well, yeah, we all do that. Your body's gotten used to that. You need to push it and tax it, move it a little bit more than that.
What role do you think physical therapy has for the stroke and diabetic stroke patient or person as they're, 5, 10, 15 years out? Should they revisit physical therapy, or should they just feel it's over?
I think we have to have a lot of touch points along the way. I think our biggest one is prevention beforehand, right? Educating and getting them, like we're doing right now, just trying to teach people what it is, what's out there, how to handle it, how to reverse it, things like that. Education on the prehab, on the, the prevention side of things is really the most important, because we can stop people from even getting to that point. 5 years down the line, I definitely think, a revisit, a check-in, let's see where you're at. Have things gotten worse? Is your mobility more limited?
Mhm.
Have you made any changes, even the small changes that we talked about? Are you working on, getting rid of the sodas, cutting out smoking, or, whatever the bad habits are? Are
Mhm.
you working on your leg strength and sit to stand? Are you exercising a couple times a week?
Mhm.
And then, 10, 15 years down the line, I mean, I think, to be honest with you, we could easily, as physical therapists, help people with an annual checkup and just see for mobility where they're at, what their, current hindrances are. Do they have anything at home that they find they can't do and that maybe needs to be looked at? Is there, an obstacle in the way, something we need to work on? Because they know their body better than anybody. So if there's something that seems like it's getting worse, they'll be able to tell you. And annually, for a stroke patient, especially one who's had it for several years, is probably a good checkup. But I think, again, it may even just be an education session, and that to me is where I feel physical therapists are probably the best equipped to help these patients 5, 10, 15 years down the line is education, and I'm not just saying that because I'm partial with an EDD and being in the academic setting a little bit here and there, as an adjunct, but like, I really do believe that we as physical therapists are all educators. We're educating our patients constantly. And if we're not doing it right.
Right.
So
Yeah.
that's where I feel like we can probably be the biggest help, is just educating them and breaking it down on a very simplistic level so they understand, and helping them realize, if this isn't working, here's how we could fix that to make it work. We're very good at adapting things, whether it be equipment or exercises or homes. We're physical therapists are very good at thinking outside the box and coming up with an answer and a solution. We roll with the punches very well. So, I feel like that's one of the big things we can help our patients with.
I would agree that, yeah, Dr. Fields just made such a great point with that education for physical therapy, and also, can people just call up a PT and get an appointment now? I mean, surely you have to go through your doctor, right, and get a script.
I think you're baiting me with this question here, being in the state of Texas.
Yeah,
So
yeah.
direct access is something that is available in all 50 states to some extent. Some states are better than others. The laws are a lot different for each state. We just got Texas to pass some laws that allow us a few days of direct access. We get 10 to 15 days of direct access depending on your education. But you can, if there's an issue, you're having aches or pains in a shoulder, leg, arm, back, whatever it may be, you're having some trouble moving, something's not feeling right, you can just walk off the street and go see your local physical therapist. That's definitely a possibility. You don't need a doctor's script for the most part. Again, it differs by state, and there are some little rules and regulations you need to follow. But if there's ever a question, just call your physical therapist. They'll know the rules and regulations. But for the most part, you can just walk off the street and get direct access physical therapy, which is nice, because I feel like as the movement experts, we know a lot about pain. We know a lot about stroke. We know a lot about, rehabbing. Obviously, as physical therapists, I think we're a very good first step for a lot of patients, especially those with stroke, and even those, like we said, with diabetes. We're educated enough to know some
Mhm.
of the ins and outs,
Mhm.
even the basics, the difference between type 1 and type 2.
Yeah.
That could be enough to really help somebody. So,
Mhm. I think the medical training too goes a long way, and that we have been working with physicians for years and years and
yeah.
years. So we're very equipped at interfacing with people's primary doctors and knowing how to communicate what's happening, catching red flags.
Yeah, you hit the nail on the head, Karen. I mean, one thing that I pride myself on, and I think a lot of other therapists do as well, is we know when to refer and where to refer. If there's something that's just outside of our scope of practice, we know immediately who to send them to and why, right? Hey, I'm seeing this and this, not normal, definitely not something I can handle. You need to head to a neurologist, or you need to go and you've got this really weird allergy when you eat this one thing. Like, you probably need to see a dietitian, or somebody who can give you a little more insight into the food allergy aspect. I mean, we know when things are outside of our scope, and we refer to the right people, I think, all the time. So we're pretty good at that.
That should give the person quite a bit of assurance, I think. If you have a health issue, you want to get strong, and you want to get back to function, and all that is within the scope of physical therapy, from the medical to determining where the deficits are and why they're there, addressing them through appropriate exercise. And then I think that you also said something very good about the whole follow-up, the annual follow-up. If your physical therapist gets to know you just like your physician, then why not see the PT once a year? And let's look at anything that's gone, awry, or it's not where it could be, and get you back into active therapy. That could even be a Medicare provided service.
Absolutely. Yeah. I mean, as long as there's a justification for it, you can fire up that Medicare, physical therapy again. I mean, it's one of those things where, if it's not being checked or monitored by anybody, it may continue to just go on and get worse. And, if we can see it and catch it early on, even if it's with that annual checkup, well, then, all right, now we can address it and hopefully get it before it gets worse.
Mm-hmm.
So
wonderful. Well, that's really good. I think we have given our listeners a lot of really good information today, and explained the role of physical therapy in treating and helping to maintain mobility for those who are diabetic and stroke, and other conditions as well. Really emphasize today the need for prevention, and I love that. Dr. Feil has mentioned that more than once, and it's doable, right?
yeah, absolutely. I mean, I honestly, I would say about 4 or 5 years ago, I was pre-diabetic and I was on a blood pressure medication. And a lot of that was from genetics, just being, overweight and out of shape, grad school, all the above gave me high blood pressure. So I was on a blood pressure medication for about 10 years, and I was pre-diabetic. And, my doctor basically said, like, hey, you're trending in the wrong direction. You know what to do. And I said, yeah, I know. I say this every year and I don't do anything about it. So, when my wife finally took over the cooking for us and got us on that whole 30 style, I don't want to call it a diet because it's really not. It's a lifestyle change.
Mm.
Once we switched to that, I was able to, drop about 20 pounds, get off the blood pressure medication, and I'm not anywhere near diabetic now. So,
Wow.
and again, I haven't done too much. I've just, gently changed my diet and walk a couple times a week. I mean, that's bare minimum, bare bones basic. And I'm looking to now start increasing that and doing more. I talked about prevention a lot on this interview here, and Mike Eisenhart with the APHPT, the Academy of Health and Prevention Promotion Therapy, they really inspired me to kind of change things for myself and get moving, and they're all about prevention and getting population health and getting the people before they become a problem, before they get to the medical system, which seems counterintuitive to a business model for therapists, but it can be done. I mean, the insurance companies nowadays are showing that the workforce is getting unhealthier and unhealthier and unhealthier, and it's just going to keep costing them more and more through their insurance coverages. So, somebody's got to cut them off at the pass. And I think, PTs are positioned to do exactly that. So.
Yeah, it's absolutely right. So how could people learn more about the kind of education that you provide and services? It would be great to know that.
Yeah. So, thank you again for having me on. And I like I said, I can be found at pteducator.com is basically my home site. I blog a little bit there. I have a bunch of courses for the public and for clinicians on there. Just stuff that I find interesting and things that I like that are a little outside the box, fantasy football injuries and video game injuries, some business stuff on there too for clinicians. But, they can always check me out too at the Healthcare Education Transformation Podcast. I'm a co-host there with Brandon Pone and Stephanie Wyrock, two people doing amazing things in the world of physical therapy and just trying to learn and teach and find the best practices possible for healthcare education. Because we're trying to break down the silos. We're trying to get in touch with all the different medical fields and professions and find how they go through schooling and what works for them and what doesn't, and how we can interact on a daily basis to help get the best possible patient outcomes that we can. And we really believe that that starts with the healthcare education system, and that's already a bumpy road. So we're trying to smooth it out and find the best practices possible. But yeah, that the healthcare education transformation podcast can be found on iTunes and Stitcher and Spotify and everywhere podcasts are found. So go give a listen to some of those episodes. There's a lot of great episodes on a lot of different topics. So again, I kind of feel like we're all educators, right? I'm an educator, you're an educator, we're all educators. So,
yes, yes. And you are currently seeing clients in what area of Texas?
Yeah, I'm in Waco, Texas, right in the heart of Texas there. I've got a small mobile PT business called Epic Therapy and Wellness. It's 100% out of network, just a cash pay business that I basically see people who really do value their health and are just kind of interested in, what they can do to better themselves and to, take care of those little aches and pains. And in the meantime, on my 9 to 5, I also do a home health therapy in the area. So, if you're ever visiting Chip and Joanna Gaines and the Fixer Upper crew there at Magnolia, feel free to stop by, or Baylor University, right? Go Bears. Feel free to hit me up and let me know. Reach out. I'm pretty accessible on social media there. All of my handles and stuff are at pteducator.com. So they can
And I
reach out to
believe
me
you
there.
even do telehealth. Is that right?
I do. Mm-hmm. Yeah. So I basically have only, as of now, used the telehealth for local people in Texas. Well, not local, Texans, mainly video game injuries. I've been working a lot with that population lately. I have done a little bit of consulting outside of the state of Texas with telehealth as well.
Right.
But it's again kind of like the wild, wild west out there. So we're all just kind of learning how to best utilize telehealth right now and what the rules and regulations are. So,
Fantastic.
trying to navigate that as well.
All right. Well, I want to really thank you for being a part of this interview and meeting the audience here. So we're going to close now, but thank you for listening. We appreciate our listeners. And I want to just let you know too, there's a Facebook group called the Stroke Movers. If you want to join us there for stroke wellness, you're certainly welcome. So thanks a lot, and we'll maybe catch you another time.
Thanks, Karen. Bye-bye.
Bye-bye.